Dr. Barrett Boody. I work at Indiana Spine Group. You guys might have seen me at the last journal club. I threw a couple relief innings for Dr. Sasso when he couldn't be at the last journal club. But I'm leading the one today with Paul Kramer, and I'm sure he'll be on in a few minutes. Today we picked a bunch of papers related to deformity surgery as it applies to degenerative principles. I think that we've had a bunch of discussions already about the value of deformity principles and pre-op planning and sagittal alignment parameters and correction. But I think a lot of the questions that still come up is, what does it relate in order to degenerative surgery? How much of these principles really should play into our practice? And so we picked a bunch of articles today, and we have a case discussion on Tuesday that's going to play off a lot of the very same principles. We did this because we wanted to create some discussion today and continue it on Tuesday. So today we have 4 articles. Really the things I wanted to hit on today was, one, what is the value of surveillance of deformity parameters in our degenerative population? So what is the value of measuring all the Lordosis and PI and PT for every single patient we see? And 2, understanding the risk and benefit of what we do. Is there value to doing the increased deformity principles to the degenerative surgery? Does it translate into demonstrable benefits and outcomes for our patients? And then 3, as we look at the different levels of evidence and the amount of evidence on the topic, trying to understand what the strength of recommendations would be from the available evidence. So if we draw conclusions from things, understanding what the limitations of the available data are. So those kind of 3 things are things I think about when we do our journal clubs. So we always encourage lots of feedback and discussion for this. We always appreciate evidence-based responses and back and forth debate on the topic, but to be honest, it's Friday. If you have any personal attacks on people, that's okay. It's encouraged, actually. If you want to call someone a criminal, it's okay. It's highly encouraged. It's a safe space. So without further ado,
doing that the last hour at TBI.
Yes, this is a safe space for disparaging your fellow surgeon. Okay, and don't take this too seriously. It's supposed to be a little bit of fun. So without further ado, let's get started with our first presentation, and we'll stimulate some discussion with that.
Hey, Barrett, who's up first?
Kayla is.
Kayla?
It's all going through Sandra's screen. So we have one screen that's going up here. And go ahead. Let's get started with the first one.
So we chose to, while Kayla's getting up there, what we've chosen to do this time is have a series of articles that all are on a similar topic, near and dear to my heart. And it's going to correspond to the interesting case discussion that we're going to have on Tuesday night. So this is the evidence, and I'll turn that into some religious fervor on Tuesday night.
Okay, good. Okay, I'm Kayla Bradburn. I'm a PGY3 resident at Indiana University, and today I'll be presenting the relationship between sagittal balance and adjacent segment disease and surgical treatment of degenerative lumbar spine disease, meta-analysis and implications for choice of fusion technique. This was an article that was published in 2018 in the European Spine Journal. For some introduction, spinopelvic sagittal alignment has been found to have a significant effect on clinical outcomes following fusion surgery, and it's also been suggested that it may contribute to adjacent level disease as well. Current literature predominantly looks at the relationship between sagittal alignment and ALD in the setting of spinal deformity, with a limited number of studies looking at this in patients who underwent fusion for degenerative lumbar disease. So the purpose of this study was to perform a meta-analysis to pool the available data to investigate the relationship between spinopelvic alignment parameters and development of ALD after lumbar fusion for degenerative disease. So for this meta-analysis, they did a search of 6 e-databases and included studies where patients underwent fusion surgery for degenerative lumbar spinal diseases, with patients split into 2 groups, those who developed adjacent level disease and those who did not. They excluded abstracts, case reports, conference presentations, editorials, expert opinions, and review articles, and ultimately the reviewers found 8 studies that met the criteria. These 8 studies encompassed a total of 253 patients who developed adjacent level disease and 860 without. These were the studies that they included. They were all single center studies. One was a prospective cohort and the 7 others were retrospective case controls. In terms of the parameters that they looked at, 6 of them looked at preoperative pelvic tilt, 5 of them looked at sacral slope, 8 lumbar lordosis, 3 pelvic incidence lumbar lordosis mismatch, and 4 looked at postoperative PI and PT. For the statistical analysis, they did weighted mean difference that they used as a summary statistic. The results were presented using a random effects model to account for possible clinical diversity and methodological variation between studies given the high level of heterogeneity. They also did a funnel plot to assess for publication bias. Here's a table that shows the underlying patient demographics. Overall, the only one that was significantly different between the ALD group and the group that did not develop ALD was that the group that did develop ALD was on average 3 years older. Otherwise, there was no underlying significant differences in their demographics. This chart looks at the preoperative spinal pelvic sagittal measurements and in terms of which ones were significantly different between the 2 groups. The ones that they found were significantly different were the PT was significantly higher in the group that developed ALD, and the sacral slope and lumbar lordosis were significantly lower in the group that that developed ALD, and the pelvic incidence lumbar lordosis mismatch was significantly higher in the group that did develop ALD. And this is the chart that looked at the postoperative measurements. So for these, they found that the group that developed ALD had a significant larger pelvic incidence and a significantly larger pelvic tilt as well. So in regards to the PT being elevated in both the pre and postoperative groups for the ALD group, patients with fixed spinal deformity have a greater PT as a compensatory mechanism while standing. So the persistence of this in the post-op group indicates that the sagittal malalignment may not be getting adequately corrected and therefore predispose them to developing adjacent level disease. A higher PI may put patients at increased risk of developing adjacent level disease because of an increased PI-LL mismatch due to the hypolordosis that is commonly seen after fusion procedures. Overall, this study suggests that spine surgeons should pay attention to sagittal alignment in patients undergoing fusion, even in the absence of overt spinal deformity. It also implies that surgeons should employ surgical techniques that appropriately restore the lumbar lordosis and PI-LL mismatch to minimize ALD. The authors also suggested that an ALIF may be the most effective for adequate lumbar lordosis restoration to reduce the development of ALD. So this is something that you could consider in patients that are higher risk. In terms of the limitations of this study, as a meta-analysis, the heterogeneity is always going to be something that's a limitation. They did have a significant unbalance between their 2 cohort sizes, with there being significantly fewer patients in the ALD group. The follow-up time was varied significantly when you're looking at the studies that they used. One of them only followed them up for 14 months. And then the other thing is that they didn't have a unifying definition or measurement for ALD, so that could introduce some bias as well. In terms of further direction, further studies are needed to establish criteria to differentiate ALD from just normal age-related degeneration, as well as future studies to investigate the correlation between spinal pelvic parameters and clinical outcomes in patients who develop adjacent level disease.
Excellent. So thank you, Kayla. I like starting with a meta-analysis because it's nice. Unfortunately, with meta-analysis, you lose the granularity of data and causal, basically causal relationships that you can create from prospective data. But it's nice for hypothesis driving and identifying what correlations are. And I think this nicely shows that there are multiple parameters in terms of sagittal alignment that even for degenerative conditions like high PT, PLL mismatch, these are things that are related to adjacent level surgery. So I think that there's a lot of data that suggests, and we'll look at this further with the next papers, but a lot of data suggests that, you know, if you identify these, that these might be risk factors. It's hard to say risk factors because it's not prospective, it's retrospective. But one of the things I wanted to ask the panel is, I already know Paul's answer. He measures every patient, but the other guys from TBI and other places, do you guys measure routinely all of your lumbosacral parameters, even for a one-level decompression fusion?
What I think is interesting about this paper is that it clearly emphasizes what we hear over and over and over again that many people take credit for saying first. There are two kinds of spine surgeons, those that create spine deformity and those that correct spine deformity. And yeah, I think everybody should be measuring that. And the pelvic tilt is something that's particularly important. And Jean Dubosset talked about that in the mid 70s and nobody listened to him when he talked about it. So I do measure on all our patients and we look at the pelvic tilt. I don't pay as much attention to the PI-LL mismatch, but we do try to pay attention to more of a functional approach to the patient. Is this someone who's going to be active? Is this someone who's standing a lot, sitting a lot? Where do we need the pelvis and the lumbar spine in relation to their activity level?
You know, Barrett, before it became
I'll answer from the other end. You know, segue back 20 years when we first started doing, which were mostly at L4-5 and L5-S1, with the goal being decrease adjacent segment. You know, back in previous days, we didn't have a whole lot of choices in terms of either cages or femoral allografts in terms of lordosis selection. When we first started doing disc replacement, we started to actually try to match lordosis at 4-5 and 5-1 because they had the sizes. We had to pick sizes. And I'm wondering if the fact that, you know, pretty much the studies have shown that adjacent segment disease is less with arthroplasty. I wonder how much of that is because we also paid attention to lumbar lordosis, particularly, you know, now that we've learned that most of the lumbar lordosis comes from 4-5 and 5-1, which is basically what we're doing. Do we measure all? I don't, in terms of you know, 1 or 2 level fusion or disc replacement, you know, measure all the parameters, but we do pay a lot of attention to lordosis at 4-5 and 5-1 doing those reconstructions.
Well, you know, it's an interesting comment, Barrett, in that, as Scott said, years ago, you know, we didn't have the same inner bodies. We didn't, you know, pay attention to try to recreate the lordosis. And a lot of those patients were fused and flat back. And with arthroplasty, for example, I'll tell you our experience, when we had a very narrow disc, and we'll tackle, you know, even the ones that are almost completely flat. In the beginning, I used to use the lowest angle, like a 6 degree, but now I've come around, and because of being conscious of the lumbar lordosis, going to the higher angle ones. And it is amazing how, you know, the whole philosophy has changed where everybody's, you know, aware of this. And I think it definitely makes a difference. I don't measure the angles, but I sort of take an eyeball. If we had an EOS in our office or in our facility, then I'm sure it'd be easier for us to do it. But I think it's something you have to pay attention to. And the inner bodies allow us to get the lordosis, whether you're doing a disc replacement or if you're just doing a anterior inner body, or even a TLIF.
Just as a follow-up to that statement, Dr. Geyer. Now, if you do an increased lordosis angle of your one-level fusion because you're trying to correct a deformity, will you also do bilateral facetectomies or posterior column osteotomy in order to make sure your facets aren't limiting your amount of deformity correction? Because I think that sometimes stands in the way of a lot of our deformity correction, despite whatever angle interbody you get in there, that you ultimately are going to be held up by the facets in the back. So would you pair that with a posterior column osteotomy if you're trying to get anything more than 8-9 degrees from your interbody?
I mean, you know, typically we don't, but the problem is when you use the very hyperlordotic cages, you're right, Barrett, because what happens, they get very narrow from behind. So I can use a higher anterior so that I have at least 8 to 10 millimeters of posterior height restoration or distraction. And you are limited. Obviously, you know, I don't use those higher angle cages. The highest ones I've used are like a 16, but I think once you get above that, if you want to get better correction, you're right, you have to do something posteriorly.
Yeah, a couple of thoughts on that. One paper that didn't make the cut for us talking about today was actually a total disc paper looking at what happens to the lordosis of the operative segment, the segmental lordosis at whatever you actually did the surgery on, and in total discs, you ended up with about a 7 or 8 degree increase in the amount of lordosis than what you had pre-op versus the fusions where essentially you held what you had. And one of the things that Jack and I talked about offline after one of the very first ones is looking at the TBI data on disc replacements and correlating, instead of fusion versus arthroplasty, linking that to resolution of back pain, just do it on purely how did you fix your lumbar distribution index and your PIL mismatch? And is it the fact that your disc replacement allowed you to auto-regulate your hips underneath you, your pelvic tilt, to a point you were happy on a minute-by-minute basis, rather than a fusion where you bought your alignment and had to compensate for that? I think that'd be really interesting to look at. But I guess data is expensive and a number of other things. But I would argue that everybody should measure every time. You don't always have to do something about it. Many times you look at it and be like, oh yeah, we're gonna be fine. But every once in a while, your eyeball or an actual measuring, you're a little surprised by just how big their pelvic incidence was, and that's, you know, a risk for finding yourself in a difficult situation a few years down the road.
Paul, I agree with you 100%. I think that everybody should have an EOS. It's just, you know, a matter of, you know, do you do all the, you know, individual X-rays in your office, have them stitched together and expose the patient to a lot of radiation, or get the EOS? We're trying hard to get them in every facility. We now have them, I think, in several of our facilities, but not,
I think the minimum, and this sounds a little crazy to say, but the minimum is standing X-rays, right? Not everybody gets standing X-rays. And then the one step beyond the minimum is to include your femoral heads on every image. If you have femoral heads and up through at least the top of L2, hopefully the top of L1, then you're gonna have a really good idea of at least where you're starting, and you're gonna pick up that, you know, potential flail situation of, actually they have, you know, 80-degree pelvic incidence and you're doing a 4-to-1 fusion. Well, you better get that one right, or you're going to chase that all the way on up the lumbar spine. Yeah,
that's one thing we do. We always do get upright films. We don't ever take supine films.
Maybe it's a good segue to go into the next paper. Do you know who's presenting the next one? Let's see. Who's next, guys?
I think it's Christian.
Okay. So Christian is our fellow this year at ISG, and he's going to be presenting our next paper for us.
Well, good morning, everyone. Good morning. My name is Chris Walchesk. I'm the current fellow at ISG. I'll be presenting the paper by Temple and others, Influence of Pelvic Incidence Lumbar Lordosis Mismatch on Development of Symptomatic ALD after Single Level TLIF. In their introduction, they mention previously identified risk factors for adjacent level disease, such as age greater than 60, pre-existing degeneration, degenerative disc disease, multi-level fusions, and then laminectomies adjacent to the fusion, as well as excessive disc space distraction during the inner body fusion. In this paper, they aim to focus on the relationship between spinal pelvic parameters and the development of symptomatic adjacent level disease requiring revision surgery, as well as the predictive value of PI-LL mismatch. So methods, this was a retrospective review, case control study. They looked at all single level TLIFs at L4-5 or L5-1 during a 6-year study period that had complete imaging available, and ended up with 159 total cases out of 322 possible. They looked at patients who required additional fusion operations for symptomatic ALD, which ended up being 55 patients, and compared them to the age and gender matched cohort who did not develop this. They excluded infections, active cancers, immunosuppressed patients, and any traumatic etiologies. They obtained pre and post-operative standing lateral X-rays and measured pelvic tilt, sacral slope, pelvic incidence, lumbar lordosis, and calculated PI-LL mismatch for both groups. The post-operative X-rays were obtained at 6 to 12 months post-operatively and were examined for evidence of arthrodesis simply on plain X-rays. And And then arthrodesis was defined as bridging bone between the vertebral bodies without evidence of pseudoarthrosis on dynamic imaging, which was also obtained. The results showed, again, out of 159 patients, 86 underwent L4-5 TLIF and 73 had L5-1. Revision was required for 30 patients after L4-5 and 25 patients after L5-1 TLIFs. ALD developed distally at L5-1 only in 2 out of the 30 patients that underwent L4-5 TLIF. And 15% or 8 out of the 55 total developed ALD. Also had grade 1 or 2 spondylolisthesis on dynamic imaging compared to only 13 out of 104 in the control group. Fusion was coded as being 94.2% in the control group and 92.7% in the ALD group at final follow-up. Looking at table 1, which was a univariate analysis of the measured parameters, they found statistically significant differences in post-op lumbar lordosis, which was lower in the ALD group. They also found differences in post-operative, preoperative difference in lumbar lordosis, again, losing lordosis in the ALD group and gaining about 2 degrees of lordosis in the control group. PI was also statistically significant by about 4 degrees difference. And then both preoperative and postoperative PILL difference was statistically significant. Pelvic tilt was also found to be statistically significant by about almost 3 degrees. They also performed a regression analysis for PIL mismatch, which is shown here in table 2. They found an odds ratio of 1.25 of developing ALD with a PIL mismatch preoperatively and a 1.4 odds ratio of developing ALD with postoperative PIL mismatch. In table 3, the development of ALD for various PILL ranges was calculated and shown. They quoted a 75% positive predictive value if your PILL difference is 11 to 25, and then 26 or greater was 100% predictive. So in their discussion, they concluded that postoperative PIL mismatch greater than 11 degrees predicted development of adjacent segment level disease requiring surgery. And that had a positive predictive value of 75%. And again, over 26 degrees had 100% PPV. They postulate that symptomatic ALD after short segment fusion may also be due to poor global sagittal alignment, as opposed to just a focal process secondary to immobilization or just genetics. In most cases of ALD, they found that the proximal segment is affected and L5S1 was relatively protected in single level fusions. They concluded that spinopelvic parameters should be determined in patients for degen conditions undergoing short segment fusion, simply to quote, document global sagittal alignment, but they did not go as far as making a recommendation to perform any more surgery or a different surgery to correct these parameters in the absence of any other indication. So some of the strength of this study, again, they highlighted the use of the pelvic parameters to predict development of symptomatic ALD, and then did give us some odds ratios with different PILL mismatches. They had several limitations. Some of it was due to the retrospective nature of the study. They did have to exclude a high number of patients from their initial cohort due to lack of imaging. They did not have any data on bone quality or quality outcome data, and it was a relatively small cohort. Thank you.
Yeah. Thanks. I like this paper because it's a relatively large sample size, but there are several flaws with this paper. One of the big flaws is that they, off the bat, threw out about 50% of their data. I mean, they started with 300 some odd patients, and then only 159 had follow-up. You know, that's a significant flaw in the data, because we don't know what happened to those. We don't know if those were good outcomes, bad outcomes, or somewhere in between. We really have no bearing, and we're working on 50% of the data, to be quite honest. And if you look at table 1 as well, this paper strikes me as patients that just were kind of fused in situ. If you look at the pre and post-op PILO mismatch, they're the same. For the people who had no ALD and ALD requiring revision surgery, they're basically the exact same. They basically just took these patients and fused them.
Barrett, I think that tells you it tells you something about the, you know, this is 2006 to 2012, which is not super early in the TLIF experience, but probably in the meat of it. And it shows you that you're probably not, it tells me a couple of things. You're not changing lordosis if you're not trying to. I think one of my favorite things about this study is they almost certainly weren't looking at PLL mismatch and trying to change them and trying to do things better. So it was a blinded in the aspect of, it looks at what people were really doing rather than looking good when they know the camera is on. And so for that, I think it's helpful. And that's what you get out. That's the data would suggest out of TLIF, you get a couple of degrees best case scenario. And in their mismatch set where there's 11 to 13 or somewhere in there off, you know, that you may not be able to routinely get 13 degrees. And I've been through the TLIF wars and posterior osteotomy along with TLIF and all kinds of stuff, trying to get as much as possible out of TLIFs with every different trick. And I do a lot of OLIFs now.
So one of the things I see in a lot of these papers that are retrospective is they identify the fact that PLL mismatch or some sort of sagittal imbalance parameter is predictive of revision surgery, but not many papers actually go into saying that if I were to do this one level surgery and correct that parameter, if I were to go from the mismatch into balanced, am I preventing reoperation? And so that's one of the questions I wanted to pose people is, do you think that, you know, and there's not a lot of data to support this. There's not a lot of data in this space that if you do a one level correction of deformity, are you meaningfully preventing reoperation? So what do you guys think about that? Do you guys think that is a reasonable inductive leap, or is that just something that we don't know if the juice is worth a squeeze for?
You know, that's a tough one, because the only paper I know that might reflect it, and again, this is way back before we were measuring a lot of these parameters, was a paper from Australia looking at ALIFs and adjacent segment. And there, you know, obviously there's a lot of factors. There's no pedicle, I mean, there's a lot of stuff. But compared to other fusion constructs, ALIFs, which, as we all know, are the best at restoring lordosis, had less of an incidence adjacent segment. Was it because of that? They didn't measure that back then because it's a 20-year-old paper, or was it because you weren't messing with the posterior musculature or posterior structures? But that's the only paper I know for a one segment. That
You're talking about Rob Frazier's article? Scott?
Yeah, Rob Frazier's.
Yeah.
Barrett, I think the value of this is to put the seed in the young guys' minds as they're starting their practice, to start, you know, looking at global alignment and maybe, you know, starting to get in EOS on all their 1 and 2 level lumbar fusions. For the older guys, nobody ever put these pieces together. And, you know, that's why a lot of early instrumentation, even Kyphost L5S1 or L4 to S1, because they were posterior distraction instruments. And it took, you know, a couple of decades before you started seeing patients coming back with secondary changes. So, you know, older guys didn't think of that. They didn't put how a cervical spine could be possibly related to a lumbosacral fusion. But I think for the younger guys now, they're all keyed into more global alignment and measuring parameters. So that's where the value of this is going to be. It's going forward and saving spines from the clutches of Izzy Lieberman and his crew.
So it's all. The thing I love about journal clubs is everything seems so black and white. You come to these things and they always seem so clear cut. But you go to clinic next and you got this 65, or if you don't see Medicare, 64-year-old. How about 64? So everyone sees Anthem here. Now you got a 64-year-old female who has a 1-level degen spondy, bilateral radiculopathy. They're coming to you for leg pain. They got a 10-millimeter slip at 4.5. They're showing some imbalance on the PLL mismatch, but they're really coming to you for radiculopathy. How do you balance that need? Do you identify that they have deformity parameters that are abnormal, versus saying, I don't think the juice is worth the squeeze of doing a front back or, you know, like a big deformity correction. All they need is screws and a decompression. That's what they came to you for. How do you balance that blend of looking at that for a patient like that?
You know, Barrett, that's the question that we have all the time. And as we tell the fellows that things are gray, they're rarely black and white. And, you know, the thing is, for years and years, we did it one way, but it's just a matter of collecting data. And as Dr. Ziegler said, it's just a matter of, you know, collecting the data to go forward and determine, does it really make a difference in a 65-year-old if you correct everything? And I had the argument with Izzy and all the deformity folks that, you know, basically we correct these 70 and 80-year-old patients to, you know, parameters compared to a 20-year-old. And does that make sense? The question or the answer is that we don't know the answer. We will know the answer in the future as we collect more and more data. But I think it's, as you said, it is a balance, and you have to take that patient's, you know, whole picture into account, their function, their activity level, what their main problem is, and are you going to do, as we say in our office, the big whack, or are you going to do something more limited for them without correcting the parameters to exactly the way they should be? Because we don't know what a 65-year-old would tolerate. You know, we know what a 20-year-old should be. We know what a normal 30-year-old should be, but we don't know what, you know, as we age and the spine ages, and there's many compensatory mechanisms the body goes through.
Barrett, I like that you brought up the fact that, is that too much of an inductive leap to assume that if we're doing it wrong, here's what happens, but do we know that if we're doing it right? Essentially what we're measuring right now is the ones that we accidentally did right? This paper said if you started out okay balanced and ended up okay balanced, you did good. If you started out poorly balanced, you ended up poorly balanced, and you did bad. It's oversimplifying a bit. But what it doesn't pick out is exactly what you asked, is if you do what you think is better, if you, instead of doing a PSF in situ, you say, I'm going to O-lift with a 18-degree cage and ideally align that segment, does that end up pushing them from somebody you would have predicted to be in the bad category to somebody in the good category? That's going to be a challenge for us, but we need to be, I think, looking at not just an all-comers, but a people who we think we took from the wrong track to the right track. And you're right, we just don't have that data. We have more and more data all the time saying, if you're on the wrong track and aren't trying, you're going to end up in a bad spot. If you're on the right track, you're probably going to be okay. That's I think points out some of the flaw.
The other thing I would add on is that there's a few of us at TBI, for that patient that you presented, an older patient, single level, grade or less slip, have embraced decompression with a Coflex. Now, our results aren't 100%, of course, we're not 100% with anything, but as far as I know, we've not created an adjacent segment disease doing a decompression with a Coflex for patients that fit the criteria for that.
And the other thing you're going to be seeing coming out soon is a Lemoflex, which is the opposite of the Coflex, which is really a spring mechanism. And again, it's for a single level spondy up to a grade 1 that have stenosis. So, you know, I think that, you know, as we go on, we're learning more and more. And fortunately, there is a move to preserving motion. You know, we have our fusions that have been our mainstay for years and years. So, you know, unfortunately, Barrett, it is gray. There's no black and white decision.
Exactly. We took a complicated problem and we found a way to make it more complicated.
Right.
We've had more answers, more solutions to something.
Well, that's the fun of what we do.
One of the things that I'd maintain is we're so fixed on X-ray parameters, and we really have to be thinking about functional parameters. What are these patients going to do? We've all seen 65-year-old patients who act like they're 35-year-old mountain biking and trying to golf, and we've seen 35-year-olds who can barely get from the bathroom to the bedroom. So you've got to look at the function more so than the X-rays themselves and all the parameters.
Fully agree. I think we should probably move on. We're about 9:35. Let's do the next paper, and we'll see if we can get some more discussion from that. So our next paper is Zach, I believe.
Yeah.
And he's doing the Rosenfeld paper about mismatch.
Okay. I'm Zach Goldstein. I'm a fourth-year resident at IU. I will be presenting the paper titled Pelvic Incidence Lumbar Lordosis Mismatch predisposes to adjacent segment disease after lumbar spinal fusion. This was a study published in 2015 in European Spine Journal out of Zurich, Switzerland. Adjacent segment disease occurs following prior lumbar fusion when patient symptoms correlate with radiographic evidence of adjacent segment degeneration, instability, and/or stenosis. There has been an abundance of literature looking at specific risk factors for the development of adjacent segment disease. I've listed some of these risk factors here, which, as you can see, include both demographic factors as well as iatrogenic factors. Prior to this 2015 study, there was a 2001 paper that suggested that global spinal parameters such as C7 plumb line, as well as pelvic alignment parameters such as sacral slope, correlated with lower rates of ASD. At that time, though, there really wasn't a lot of other literature that had looked at other spinal pelvic parameters. And as you can remember from Kayla's meta-analysis, a lot of those papers seem to kind of come out around the same time, that 2017 time period. Due to the growing understanding surrounding the importance of spinopelvic alignment, the authors of this study sought to determine a relationship between spinopelvic parameters and ASD, specifically spinopelvic alignment as a risk factor for the development of adjacent segment disease. This was a retrospective case control study, level 3 evidence, that included patients who underwent single to 3-level lumbar fusions. ASD group included patients who developed symptomatic ASD requiring revision surgery. They excluded patients with lumbar deformity, such as scoliosis or isthmic spondylolisthesis. An age and gender matched control group that underwent primary lumbar fusions during the same study period was identified at random. This control group had a minimum of 5 years follow-up and did not demonstrate symptomatic ASD. The study included 84 patients, 45 in the ASD group and 39 in the control group. You can see here that age, gender, BMI, and number of segments were similar between groups. In order to control for pre-existing disease at the adjacent segment that may have served as a confounding factor, the authors characterized the adjacent discs using the Firming criteria, which is a grading system that assigns grades 1 through 5 for disc degeneration based on several categories seen on MRI, including degenerated intervertebral discs, asymmetry in disc structure, distinction of the nucleus and the annulus, signal intensity of the intervertebral discs, and the height of the intervertebral discs. As you can see from table 3, the preoperative adjacent disc spaces were similar between groups. The results of the study found statistically significant differences in several spinopelvic parameters between groups. ASD patients had less lumbar lordosis and an increased pelvic incidence, pelvic tilt, sacral slope, and PI-LL mismatch. Using statistical regression analysis, I identified the PI-LL cutoff value of 9.8 degrees as the most sensitive differing parameter between the groups, with a sensitivity of 73%. When they classified patients into type A and type B spinopelvic alignment, with type A being a PI-LL mismatch of less than 10 degrees and type B with a PI-LL mismatch greater than 10 degrees, they found a 10-fold higher risk of developing ASD for patients with a mismatch greater than 10 degrees. So in summary, this study added to the existing literature on the importance of good sagittal alignment and specifically spinopelvic mismatch. A quantifiable cutoff of 10 degrees as a risk factor for the development of adjacent segment disease makes sense given similar cutoff values that have been found to correlate with disability and quality of life scores. I think the main take-home point of the study would be the suggestion that when fusing segments of the lumbar spine, you can't just ignore pre-existing poor spinopelvic mismatch. And instead, we should pay careful attention to this, and correcting this imbalance is actually necessary in order to achieve an excellent clinical outcome for these patients. Overall, this was a good study. However, limitations include the retrospective design and the fact that they only considered lumbopelvic alignment and not global spinal alignment, given the fact that they did not have access to whole spine films for enough patients preoperatively. Whether or not global alignment plays a role in the development of ASD cannot be concluded from the results of this study. Thank you.
Thanks, Zach. And usually I get in the weeds about statistics and methods, but I don't want to do that this morning. But the one thing I think that's important that it commonly gets misstated from this is, and the authors made an error in doing this, is that an odds ratio of 10 does not translate into a risk of 10-fold greater. It's a misunderstanding of what the odds ratio is. It doesn't adequately sample what the population is. It's a case control, as well as when you start getting odds ratios above 1 and less than 1 that reach extremes of multiples of, we start to get 10-fold higher than 1, it begins to significantly overestimate the relative risk. So when we say things like risk, that's actually, we're trying to say that it's a relative risk, and that's actually a misunderstanding. of the retrospective nature of the odds ratio. So I see that quoted all the time, and I think it's a mistake by the author. Nonetheless, they do point out that there is a big odds ratio, that there is a risk of having reoperation and adjacent level disease from this. But I think it's important for the young guys to know that that's a misinterpretation of what an odds ratio is. I picked this because I think it's one of basically one of the first papers that I think that really pointed out the importance of PI-LO mismatch for reoperation. And I think it's important for the young guys to know this because it gets quoted all the time in our boards and in our OITEs, and it comes up on research and stuff. One of the things I wanted to talk about additionally, so we talked a little bit about 1 level, but degenerative stuff usually goes 2 and 3 levels. So kind of going back to the panelists again, how does a number of levels of degenerative disease, and I'm kind of going more toward the people that say they don't measure, the guys who don't measure routinely for a 1 level. Do you measure for a 2 level? Do you measure for a 3 level? And kind of what's your threshold of saying this is crossing into a deformity versus just a degenerative surgery that I'm doing? Like I know that Scott said he doesn't measure routinely, but Scott, do you have a certain threshold of what you say? I am beginning to think of this a little bit more like a deformity. Like what's your threshold of saying this is not just a simple degen case?
You know, I think this is way oversimplifying, but I think when you get to more than 2 levels, I mean, I think, 3 levels or more, it's a deformity case. Obviously there are exceptions, and a lot of it's age dependent as well. So most of our younger patients are 1 and 2 level. And so, and they're at 4, 5, and 5, 1, like we talked about before, where, we do pay attention with the interbody grafts or the artificial disc, the lumbar lordosis. The older patients, obviously I'm listening to all these papers and I appreciate some of the issues, but, go back to the case you presented before. If you're treating stenosis and they happen to have, disc degeneration, disc states, height loss of lordosis, maybe a little bit slip, I don't know that it's really worth trying to hit a home run on that particular group of patients, unless you're going, way multi-level and, you're worried about PJK if you're going higher up in the lumbar spine. I think in the low lumbar, you do what you can to treat the symptoms and do the best you can not to, what did Izzy say? Make deformity as opposed to corrective.
So you mentioned that 3 levels kind of threshold of saying it's a deformity. Does the location of the fusion matter if it's a 2 level? Like for example, when you say an L4 to S1, even though it's a 2 level fusion, does the location of that level of fusion play a role in how you think about deformity?
Yeah, I think as you get higher in the lumbar spine, you have to, I think you need to be much more attentive because, the quickest PJKs or the quickest adjacent segments we see are the ones that are in the mid to upper lumbar heading towards the TL junction. So obviously those are more sensitive to a rapid development of adjacent segment disease.
I think that when we're talking about numbers of levels or how many you need to fix the problem and where it goes into moving from degenerative stuff to deformity stuff, one of the things that one of the skills that I think we all have to have is the ridiculous amount of lordosis at a short segment. And that's where hyperlordotic cages and anti-release and a lot of our, this is, if we look at this case that Zach has up there, it breaks some of our rules, I guess, right? There's obviously no lordosis or very little from 4 to 1, but a very low pelvic incidence and no pelvic tilt issues. So it's you don't actually need that much on a degree basis, but you gotta get all of it. If you just do a fusion in situ at the 3-4 level, you're gonna end up with the same thing, coming again. You can actually see a little bit of lordosis of the 2 discs above. So I think the skill set that this should open all of our eyes to is the ability to get a massive amount of lordosis at a single level rather than going down. I'm just old enough to remember the bad name all of us who are interested in deformity and spinal pelvic alignment got in the sort of early 2010 to 2012 period, where suddenly everybody wanted to do a PSO and the numbers of PSOs just went up. Somebody looked at this and said, hey, it needs a PSO, maybe not this one, but there were tons of PSOs being done. We ran into all kinds of problems. There were tons of long fusions because you got 5 degrees per level and you sort of eked out a little bit at a time over a whole bunch of segments. And I think the way to think about these is to say, okay, if you got to fix it. So we got to maximize what we got. Take the levels that you got to do surgery on, and then maximize the alignment of that, even overcompensating, right? That 3-4 has to not only have 3-4 alignment, it's got to have what 4-5 had or didn't have.
This is great. I think what this has done, Paul, it's brought out the point that, hey, as you said before, we need to be very cognizant. We need to make the measurements, and even of those of us that don't do it regularly. In fact, I took a picture of one and kept it on my iPhone. So I'm a believer, and I've always been a believer. I just haven't done the measurements. I've always tried to, maximize the lordosis, whether it's through the fusion cage or through the disc replacement at the lower 2 levels, which is mostly what I do.
So
yeah, I think if you're going to do an operation, and there are some principles that are somewhat agreed upon to adhere to, you might as well do it right, and potentially decrease the chance of problems down the road.
I think it's a good segue, Barrett, into our last article.
Are you going to talk about this case that the X-rays are up? Are you going to present that, or?
I think that was from the paper, and I actually think that CT is not actually that X-ray, to be quite honest. Looking at those two back and forth doesn't quite make sense. Others.
You're right, because the 3-4 level is much more narrowed on the plain X-rays.
Yeah, I don't think those are the same.
You've got a little bit of a list of these, but maybe just a comment on that one X-ray though. Let's go right back to the beginning. Was the way 4-5 was treated the most appropriate? And you see 5-1 is down. And Paul, with all due respect, I don't know that you can tell on that X-ray that there isn't a pelvic tilt issue there. I think there may be. You can't see the pubic symphysis there. So you've got to get that harmonious lordosis starting at 5-1, 4-5, 3-4. And then the question for that particular X-ray would be, hey, am I addressing 5-1 and 3-4? And oh, by the way, 2-3 already looks like it's breaking down. Where am I starting and stopping? And that's where I say go back to what the patient function is like and address the patient's function, not really focus, well, pay attention to the X-rays, but think of what you're trying to gain in terms of function for that patient.
Yeah, that's a great segue into this. This last paper where we kind of think about not only the mismatch, but what we're trying to do at each level. So our last paper is Jeff Konopka, who's one of our new surgeons we just brought on here at ISG. He came from Harvard, and he's going to be helping us out here in next couple months. So go ahead, Jeff.
Perfect, thanks, Barrett. So last but not least, I get the task of discussing this paper that seems to be kind of a stepsister of the GAP study. Or part of the GAP study, called Relative Lumbar Lordosis and Lordosis Distribution Index, Individualized Pelvic Incidence based proportional parameters that quantify lumbar lordosis more precisely than the concept of pelvic incidence minus lumbar lordosis. Quite a mouthful. This is done by the European Spine Study Group. It was published in Neurosurgical Focus in 2017 and was a retrospective multi-center study at 6 sites in Europe. And so the background, I think where this was born out of, is that there were limitations known with the Schwab parameters, and those being mismatch minus 10, SPA less than 4, pelvic tilt less than 20 degrees. And that system had a very difficult time describing very high and very low pelvic incidence in that range. It also had this arbitrary kind of plus or minus 9 degrees that really kind of prevented doing things in a reproducible manner in terms of preoperative planning. And so what they tried to do here is to compare the relative lumbar lordosis and mismatch and their ability to predict mechanical complications and their correlations with health-related quality of life scores. And so their inclusion criteria was 18-year-olds that had either 4 levels or more posterior spinal fusions, had greater than 2 years of follow-up and one of the following, either a coronal Cobb angle of greater than 20 or an SVA of greater than 5. They looked at outcome data and they defined mechanical failure, as you can see here, as PJF, PJK, DJF, DJK, rod breakage, screw loosening, implant dislodgement, and then for the health-related quality of life measures, you can see here they use these systems in order to measure that. Radiographically, at 6 weeks post-op from their incident procedure, they calculated they measured pelvic incidence, segmental lumbar lordosis from L4 to S1, lumbar lordosis from L1 to S1, and then they use these parameters to calculate the RLL, LDI, and pelvic incidence minus lumbar lordosis. And you can see the RLL is really what the lumbar lordosis from 1 to 1 was, minus this correction factor, and they used this from asymptomatic patients with particular PIs. And they got a category into these 4 categories: hyperlordosis, moderate hyperlordosis, aligned hyperlordosis. LDI was done as a ratio, basically looking at the bottom segment, the 4 to 1, S1 segment divided by the overall lumbar lordosis from 1 to 1. And then gave that essentially a percentage, and they sub-stratified these in the 4 categories here as well: severe hyperlordosis, moderate hyperlordosis, aligned, and then greater than hyperlordotic. And then the old, just pelvic incidence minus lumbar lordosis, this was quantified into 3 groups: less than 10 degrees, 10 to 20 degrees, and then greater than degrees. And so overall of these 222 patients, 45% of these patients had mechanical complications, a lot. 22.5% of these required revision surgery, 9% required 2 or more revisions. And so when trying to look at correlations between RLL and mismatch on PI, there was a statistically significant correlation between PI-LL. But if you actually look a little bit more into the statistics there, you look at the actual correlation coefficient, and it's been a while since I've done basic statistics, but 0.4 is usually not a very good fit for linear relationship there, but statistically significant. The HR, the health-related quality of life scores, both groups, RLL versus a mismatch group, both showed statistical significance. The p-value was smaller using the RLL. This looks at the comparison between mismatch and RLL. As you can see, both show some statistical significance, and you can see the further you get away from kind of the aligned group, the more complications you have. When doing this particular model fit, they found that the data was superior for the RLL subgroup. And then if you subclassify and you look at all the different mismatch groups being 0, plus, and double plus, you can see that these are broad categories that when you use the RLL and combine with that, there's quite a bit of a difference between that. So for example, in the 0 group, you look at it and say all comers, there's 38% mechanical complication rate there. But if you look a little closer and you use those other calculations, you can see that there's some granularity between those two, where if they're aligned according to that, they're significantly less, and you can see that kind of bores through in the positive and the double positive groups there. And then so lastly, when you look at the aligned RLL and then look at the LDI, you can see that difference gets kind of even better when you do those combined parameters, to where in the quote unquote aligned, or not aligned group, but mismatch less than 10 degrees, that overall complication rate is 38. Whereas if you look at the aligned RLL and LDI, those complications are only 12.6%. And so conclusion, so I think this is a step in the right direction in terms to better kind of quantify what our parameters are, and they can help us predict and prevent patient mechanical complications in the future. I think comparing the old Schwab, criteria, I think a lot of these, quality of life measures really are very similar, both being statistically significant. And I think it is great that we can take a look at our X-rays six 6 weeks after, and we can prevent which one of those guys is going to go on to have a failure, boy, it'd sure be nice to know, on the front end of that, how we can use some of this data in order to prevent and do some preoperative planning in order to make sure that we can minimize these complications.
Yeah. Thanks. The reason I picked this paper, it doesn't directly apply to our talk today, but I think it brings up important limitations of the models we've created for identifying sagittal imbalance. So we initially thought it was a mismatch. And what this shows us is that it might be more complicated than that. There's Lordosis distribution index, there's the relative lordosis, there's different other parameters we're looking at now that may better predict mechanical complications from these issues. Now, again, this is for a 4-level fusion and more. This is for deformity surgery, but I think as with deformity, what we've seen is that these numbers have trickled down toward degenerative surgery over time, and it's just a function of time before it begins to roll over into degenerative the space. And as we get better software with our computers, I think we'll start seeing software kind of take over these functions for us, and that's what the help is, because it's cumbersome to calculate the RLL and the LDI and all these different parameters for every single patient. It's extremely limiting when we start having high numbers in our clinics. But I think that's one of the things I look forward to in the future is having this automated. You pull up the X-rays on a screen, all everything is all calculated for you. And I do think it's important to know where the next models are going in terms of how we think about sagittal imbalance, even on the degenerative space. And that's kind of why I brought this up, because I think it's something that we need to think about and look more into as we go forward.
I have a quick question. I'm Mike McCarthy. I'm also one of the new guys here at ISG that just joined with Jeff. Are anyone using formulas? I know that a lot of the spinal deformity groups, specifically the ISSG, has come out with formulas, and it's all over the map looking at TPAs and SPAs, and the inclusion for some of these formulas are really kind of mind-boggling. But has anyone found any specific formula that they have been utilizing and got some good use out of it?
That's one of the reasons that I like this paper is I've been saying for a while that if you get 4 to 1 right, you're probably going to be okay. If you get 4 to 1 wrong, you're going to fight it the entire length of the spine. And that's essentially what lumbar distribution index says. Basically, you got to get 4 to 1 right, and you're going to be better off. I totally agree with Barrett's comment, and you were alluding to the same thing, that as this gets more and more complicated, we're going to have to offload this of our brains and our gestalt and our experience, because experience comes from bad judgment, and judgment comes from experience, and experience comes from bad judgment. So I think that Barrett is entirely correct that the future is basically a readout that says, hey, this is where they're supposed to be, this is where they are, and then you figure out how do you get them closer to where they're supposed to be, even though in revision surgery, we kind of always have one hand tied behind our back. I hope we get to that point relatively soon. Not that we need more technology to put screws in, we need more technology to tell us where we need to be, and we need more ability to manipulate the spine into those positions through as short of a segment as possible. I understand Izzy's comment a second ago that some people just need long fusions, and you got to look at the functional level of the person, but I think a really critical skill, and what a lot of my practice has turned into, is massive lordosis through short segments, especially any open segment you have from 4 to 1. If you get 4 to 1 right, you're probably okay. And if you get 4 to 1 wrong, you've got a chance to be a hero at 3-4, but you might be in trouble.
ISG guys, thank you very much for doing this. We look forward to Tuesday night, go over some cases and clinical applications. All right, let's go to work, and everybody have a good weekend.
Very good.
Be safe.
Good job, everybody.
Hey, Rick showed up. Hey, Rick.
Rick, do you want to add your 2 cents at the end here?
Yeah,
I was going to say, the voice of reason for a 1-level degenerative spondylolisthesis in a Hoosier here in Indiana, a simple decompression posterior instrumented fusion works very, very well. There's no data right now that supports doing all this stuff and doing a front and back matters. The data is still lacking, and I'm looking for it. Prospective randomized trial that shows that this stuff matters. So
that is very old school, Rick, but that's great advice. That's great advice. Thanks.
Take care. Bye-bye, guys.
Everybody have a great weekend. Bye-bye.
Thanks for watching. Hit the subscribe button for more medical content.